Okay, so we had this collection of talks, and some related to Chiari and so on, but really the theme was Syringomyelia and CSF physiology. And as I said at the beginning, we posed some questions about what causes Syringomyelia and recognising that we need to understand what causes Syringomyelia in terms of them being able to determine what's the right treatment. And we could think about Syringomyelia in terms of Chiari-related, post-traumatic, and other sorts. And so that we had this series of talks covering what is it that causes Syringomyelia. We broke that up into what are the clinical clues, and Andy spoke about that. What are the laboratory studies, meaning particularly experimental animals? One of Lynn's team spoke about engineering studies. Claire Rusbridge, who's the neurology, neurosurgery vet from the United Kingdom, spoke about her experience with dogs. And so out of all that, we're trying to work out what is the evidence for what is the underlying problem for what cause of Syringomyelia. And I have to say, I think the answer is we still don't know. We really don't know. We have a reasonable expectation that this is likely to be fundamentally related to the dynamics of cerebrospinal fluid in the spine, but I don't think we're even completely sure about that. So it's a big, for me, a big field that needs to be addressed. And then we had some more clinical talks. So we talked about, a paper from my group about how to best manage patients with Chiari malformation who'd had surgery and then the syrinx recurred. We had laboratory studies on CSF, so we had some talks here about CSF physiology. A talk from the Niagara group, so that's in Rochester, leading the world really in terms of trying to understand how CSF physiology works in the brain and spinal cord. Some really exciting stuff from there. A talk on how CSF drains into lymphatics. You probably understand about lymphatics, where in other parts of the body, fluid drains goes through the tissues and then gets back to the heart, not just through veins, but through the lymphatics. And in the brain, there are no lymphatics, but there's evidence that there are lymphatic connections through the dura. So that's an interesting aspect of fluid physiology. Another talk from my group, we've done some experiments trying to understand how fluid gets into the spinal cord and where it goes to get out. What are the factors that influence that? And we've shown that breathing and breathing pressures, blood pressure, heart rate, all have influences on how much fluid goes through the spinal cord, and these things may influence how a syrinx develops, although that's still work that has to be done. So then MRI studies looking at CSF flow. And then a bunch of papers we heard from one of the Chinese surgeons about how they're doing minimally invasive surgery for Chiari malformation. It's I've been to watch them do it. It's really impressive. Pediatric. We heard a couple of papers about. Actually, this was a talk about the results from doing post-defossate decompression without closing the dura, and some of the complications that arise from that. Some more clinical talks about Chiari, and another veterinary study. Probably could go on to there. Jörg Kleekamp, German neurosurgeon. This was a session on non-Chiari Syringomyelia. So we had that session on Chiari Syringomyelia, looking at animal studies, clinical studies, engineering studies, and dogs. And then for non-Chiari Syringomyelia, same thing, clinical clues, laboratory studies, engineering studies from Lynn. John Heiss from NIH talking about how spinal cord tumours might cause Syringomyelia. I have to say, I think that the end of all of that is that we really don't have any underlying theme as to how syrinxes form. I might just skip straight to this, where we try to go for the consensus, and we're talking about the main issues. You may understand that there's there is not a clear definition of syringomyelia, that sometimes there is a fluid channel that's visible inside the spinal cord on an MRI, and that will often be reported as a syrinx by the radiologists, but the group actually all agree that that's not a syrinx, but the point at which it becomes a syrinx is still perhaps a little bit unclear. There was a discussion about whether having a syrinx can cause spinal pain at the level of the syrinx. So, for example, if you've got a syrinx in the mid-thoracic spine and your clinical problem is pain in the middle of the thoracic spine, is that caused by the syrinx? And I think there was really disagreement about that. I think some people felt there was a possible relationship. It's certainly something I see fairly frequently, patients presenting with spinal pain, and the imaging demonstrates a small, what might be called a syrinx, and I've usually taken the view that that's not responsible, but I have to say we'll keep an open mind on that. This came from a talk by Scott Falsey, who was really talking about post-traumatic syringomyelia, and he showed some cases where the patient presented with a thoracic syringomyelia, but one of their symptoms was upper limb sensory disturbance. Now, clearly, if you've got spinal cord damage in the thoracic spine, that cannot be causing problems in the upper limb. But the issue here was that if the cause of the syrinx was actually scarring around the spinal cord that's potentially pulling on the spinal cord when you move, it might affect the cervical cord and cause upper limb symptoms. So that was an interesting outcome for me. Occult tethered cord, so many in the audience will probably understand what occult tethered cord syndrome is, right? Where there's the concept is that the lower part of the ligament at the bottom of the spinal cord is tight and there's tension on the spinal cord. Does that cause syringomyelia? It's certainly associated, but how it causes it is unclear. We had a discussion about whether or not it would be appropriate to treat a patient with syringomyelia if they had absolutely no symptoms. And I've put the word scoliosis there because remember at the beginning I said if a person has scoliosis and they've got syringomyelia, we all accept that that's associated. There can be questions about whether they should be treated as part of the management of scoliosis, but it is a consequence of the syringomyelia. What I'm talking about here is that we all see patients where either they've got Chiari malformation that's not particularly symptomatic, or it's been detected incidentally where they will have what may be a very significantly large syrinx, but the person's not symptomatic or very minimally symptomatic. And so we talked about what are the indications for surgery there. And I think the general feeling was that there's potentially a role for what you might call prophylactic surgery if the person's got a syrinx that's so worrying that you're concerned about the person developing symptoms. But I must say the discussion actually for me was much more on the conservative side than I was expecting. There were a lot of surgeons who said they really would err on the side of not operating even with a very large syrinx. So that was interesting. It's pretty clear that if we can identify the cause of the syrinx, then we should be treating that. Everyone agreed on that. If the cause of the syrinx is extensive arachnoiditis, now one of the causes of syringomyelia is a lot of scarring around the spinal cord. We're not talking here about spinal cord trauma. So if you've got a spinal cord injury that then leads to syringomyelia, the scarring tends to be very focal, and there are other reasons why you can get focal scarring. We're talking here about patients who've had meningitis, they've had a subarachnoid hemorrhage, they've had an investigation more than 20 years ago with an oil-based myelogram dye. We're using Myodil. That was a problem in this country too, John. But but you would have done 30 years ago. Yeah. So there are patients with very extensive scarring around the spinal cord who present with syringomyelia. That is an incredibly difficult problem to treat, and there's nothing really that's been demonstrated to be helpful for those patients. We talked about developing a agreed upon outcome scale in the same way that we've now got a couple of outcome scales for scores for Chiari malformation. We need the same thing for syringomyelia. And this list came from Jörg Kleekamp, and as Andy said, a German neurosurgeon, very meticulous about recording his experience, and he records these outcomes. We talked about adding on to that bowel and bladder disturbance, what else? Scoliosis, that's right. Bowel and blood disturbance and scoliosis. Onto that as a common outcome measure. And we need a lot more work done on what causes syringomyelia to start with, because that ultimately, if we can understand what's causing it, that will influence how we treat these patients, right? So, okay, we'll go on to the questions. Question number 11. Are there any activities the person with a syrinx or Chiari should stay away from to lower the chances of further damage? Perhaps I could make my comment first. If someone's got a small syrinx that's asymptomatic, I don't put any restrictions on that person. But if they've got a large syrinx, and bearing in mind that an MRI can't tell us what the pressures are, but if the person has a very large syrinx, distended spinal cord, I assume that syrinx is under relatively high pressure. And I think we would all accept that there are circumstances where such a patient with activities such as coughing, sneezing, very significant exertion with Valsalva type manoeuvres, holding the breath, straining, that the pressures transmitted from the thorax can increase the pressure in that syrinx, and that can cause it to push apart the spinal cord tissue and cause damage. I think we've all seen patients where after a period of bad respiratory infection, they come and say, well, I was fine before, they had a couple of weeks really bad coughing and sneezing, and now I've got this numbness and things down here. So the one thing that I tell these patients, if they're not having treatment, is to avoid Valsalva manoeuvres wherever possible. Comments from the panel?
Would agree. Stool softeners as well.
Okay, I think number 17 was about pain management. I think we covered that with the Chiari ones. Question number 25, idiopathic syringomyelia. Does it exist? We did talk about that at the conference, and I think most people would say that syringomyelia is always a result of something else. Chiari malformation, spinal cord injury, arachnoiditis, something is perturbing the CSF physiology, or there is something that is causing it, rather than it just being a completely sole condition. So the word idiopathic means that there is no other cause for it. The issue, though, is determining what is the underlying cause. And so we saw quite a few talks about very sophisticated imaging that can help us to find the underlying cause. But I think it's true. I think your CLICAMP says you can always find the cause. I'm not convinced about that. I think that there are many patients where we can't find the cause, but we just assume that it's there, we just can't see it.
I support Dr. Batzdorf's evidence that there's some cases that it's a congenital central canal. So basically when we're fetuses, the spinal cord is a plate and it's going to roll closed, and we're going to all have a central spinal canal. It's thought to disappear within the first few years of life. MRI is so sensitive that some of these collections are now seen. They tend to be pointy at both ends. They're right in the center of the canal. They're not broken out into the tissue. And I certainly have, it's not that I've asked them to follow up with me, so keep that in mind. But every month I might see, well, at least one, if not two, that somebody said it's a syrinx, but it looks like they have no symptoms. There's no disruption into the tissue. It's fusiform on either end. And I do view that as a persistent central spinal canal, a congenital change. It's believed to be about 5% in the Japanese population. It's not been studied in the U.S. That's the only thing I'd add.
The second part of that question was about Chiari 0. And I would answer that by saying that sometimes the cause of, or the associated thing with the syrinx is at the craniocervical junction, but it doesn't have to be Chiari malformation. And identifying that physiology, I think we rely a lot on dynamic MR imaging, not just cine CSF flow, but looking at the cardiac gated motion of the tissue. And I can show several cases where, if you look at the standard MRI, any neurosurgeon would say that's an idiopathic syringomyelia. But with the dynamic imaging, it's very clear that the pathology is at the craniocervical junction, and that's where we operate, and the syrinx gets better. So I think Chiari 0 fits into that. It's that there's pathology at the craniocervical junction, but the standard imaging appearances don't match Chiari 1.
Yeah, I think there's proof of that with the achondroplasia population who have craniocervical stenosis based on their anatomy, and will have syrinx, and decompression shows that it gets better. So I think just to highlight that comparison.
And the other thing that can add to that is cross-section pictures, images through the foramen magnum as closely as you can. Even in someone with 3 or 4 millimeters of tonsillar herniation, you could see that it's quite packed. Those are uncommon situations, but they do occur.
Okay, and question 26 is, does a syringomyelia cause other sorts of symptoms that may not be typical? I mean, the typical symptoms are sensory, because that's the part of the spinal cord that gets affected most commonly with syringomyelia. But there are patients, particularly if the syrinx is low in the spinal cord, where the manifestations may be particularly bladder control. But I don't think the other things, the POTS, neurocardiogenic syncope, digestive issues, heat intolerance possibly, that's related to the sensory disturbance, blood pressure issues, I don't think they're specifically related to syringomyelia. No. Okay. Number 36, can small syrinxes cause symptoms? The answer is yes. And again, this comes to the fidelity of the imaging. The radiologists may not see this sometimes. They'll say it's a small syrinx. But if you carefully look at the axial images and you see that the syrinx is dissected into the spinal cord, it's not just that central normal fluid column that's slightly expanded, it's actually broken into the spinal cord tissue, and that matches the symptoms, then yes, it's clearly the cause of the symptoms.
Yeah, and in addition, in some patients, the syrinx will get so big that it'll blow out into the spinal subarachnoid space, and then it'll shrink down. But you can see the irregularity, and actually you can often see on the backside is where often it'll burst out. Those are people that maybe weren't diagnosed many, many years ago and lived it for many years.
Yeah, and the other end of that spectrum too is that you can have a very large syrinx, and I can show you a picture of a syrinx going right up into the brainstem, expanding apart the medulla, and the person being completely asymptomatic. So size doesn't really tell you. Number 74, how long before science can prevent and cure syringomyelia? When are we going to understand what causes syringomyelia? Lynn's going to find the answer.
The obvious answer is, of course, we don't know. And we're working as fast and as hard as we can. And I think one of the things that was really encouraging about this conference was the multidisciplinary approach that's now being taken, not just by our group, but by other groups, both in this country and in Europe. And Marcus and I are going from here to another conference in Norway, actually, which is more engineering and imaging focused. But again, multiple approaches are going to be required to do this. I wish I could tell you I was going to be able to find the answer tomorrow. But we're trying to think as laterally and as hard as we can, and it really research just takes time, unfortunately.
Okay. Number 75 is, if a laminectomy is performed to treat syringomyelia, can the spine stay stable, or is some reinforcement, and I assume fusion, needed? Is this question different in children and adults? I think in children it seems pretty important to put the lamina back wherever possible to keep the spine in alignment, or keep the tension of the spine.
It depends on how many levels and how old they are. We don't always use instrumentation. Sometimes we can suture it back to the surrounding musculature.
But in general terms, my approach is that it would be very uncommon for a fusion to also be required. And one way to think about this for the spine is that there are 3 columns. There's the front column, which is the discs between the main bones of the vertebra, and at the back on each side is a joint. And they are the 3 main constructs that hold the spine together. The lamina is between the joints, and if you remove the lamina but leave the joints intact, it's unlikely that the person's going to have problems with stability. particularly in the cervical spine, if you maintain, there's a very strong ligament at the back of the neck. If you maintain the integrity of that structure, that will tend to keep the neck in alignment. So for me, it'd be very unusual for a fusion to be required. Do others want to comment on that?
Agree, and if it's a shunt procedure, then it's going to be a very limited opening.
Absolutely, yeah. Okay, number 76, if a syrinx is decreased in size, and I'm assuming here after treatment, what are the chances that the damage the syrinx has caused will reverse? And this is a great question because for me, the goal of I'm going to take these questions. So, the goal of the syringomyelia treatment is to get the syrinx to collapse. It's the tension inside the syrinx that I think poses the risk for causing further spinal cord damage. And so the goal for me is to reduce that tension. Now, it's like a balloon. Balloon is blown up, and when it bursts, it collapses, you'll still see a cavity. So many, if not most, of the syringomyelia patients, as long as it collapses, you will still see a cavity. That's fine. The tension is out. They're not at risk of further damage. But will the damage that has already occurred reverse? Generally, no. It's like any spinal cord injury, the injury has occurred. And in fact, it can get symptomatically worse. And this has been fairly clearly demonstrated. The problem with syringomyelia is it tends to damage the part of the spinal cord where the sensory fibres come in, and particularly the pain sensory fibres come in and make their connections. That's damaged, and so patients will often present with loss of sensation for pain. When you treat them, the syrinx collapses, and in some patients, that part of the spinal cord starts to repair as best as it can and seems to generate pain. So I always warn patients about this. After treatment, what I'm hoping to get is an MRI that shows your syrinx is smaller, but your pain may actually get worse. And if that happens, it's usually temporary, but it can go for a year or two. You see that too?
I mean, there's clear literature to show that acute collapse of a syrinx can cause acute new symptoms, and they get better. I don't know that I've seen a tremendous amount of pain afterwards, though, to be honest.
It's not common. It's not common.
Okay.
It's not common, but it does happen.
It does.
Yeah, and the pain can be quite disturbing. It's a neuropathic pain. It's a burning dysesthetic pain. And so you try medical management, maybe acupuncture, needles, whatever might work. Can be quite troublesome to some people.
Yeah.
I do want to make the statement that when I manage patients about syrinx, I agree. I say the purpose is to treat the tension and to alleviate the progression of any problems. But I would disagree that the damage is already done. I have seen, it's not all cases by any means, but I have seen quite a few patients improve objectively in their symptoms afterwards. So
Sure.
I do think that there's the possibility that certain tissues, similar to stroke, has been completely affected, and others are either temporarily or in this transition that you can still reverse.
Oh, sure. I completely agree, but I try to lower the expectations, right?
So there was one talk this week where somebody, I think this was Chiari-related syrinx, and they said basically that even when the syrinx resolves, 2/3 of patients have ongoing symptoms. So just to give you a ballpark.
And another point to make, I think, is that if there has been some spinal cord damage that has been done by a syrinx and then it's been successfully treated, as the person gets older, they will lose function, just because as we age, we lose function. And if your spinal cord has been affected, you're just going to lose function a little bit more. And so it's not an uncommon thing for me to see patients come, they've had a syrinx treated 20 years ago, now they're in their 60s and 70s and starting, things just aren't quite as good, and there's nothing new on the imaging. And I think that's just an age-related phenomenon and what I might call reserve. They don't have as much safety margin and they're losing function.
Years ago, the real example of this was the post-polio syndrome. Yeah. So people had polio in the 50s, maybe even early 60s. A lot of them did therapy, regained a fair quality of life, but then later on in life, they're finding themselves lose ability steadily, and some will go into the wheelchair probably because of this, the loss with aging that you pointed out.
Okay. there were a couple of other questions, and I think we've covered most of the things. There was one about the vascular narrowing. But I wanted to just spend a couple of minutes covering what I classified in this list as general questions. And they generally related to how do I find the best doc? What questions can I ask? And I think we touched on that a little earlier. As I said at the beginning, it's not our role here to try and tell you who to see. But I might just start the discussion by saying, by agreeing with John Oro, that you are entitled to discuss these things with your doctor. Go and say, we don't necessarily like it if a person comes in with a printout like this from the internet and put on your desk and say, what do you think of all this? But an informed patient is a great thing. You can have a discussion with them. Like I love when I'm talking to a patient about, say, posterior decompression, I'll say things like, I'm sure you've come across the issue of what patch to use, and I'm sure you've come across the issue of what size of thing, and we can discuss it. That's a very useful thing, rather than me just trying to be didactic about it.
I mean, in the ideal circumstance, you would have a multidisciplinary clinic that we have here for a variety of other conditions that would include multiple providers, including us from neurosurgery, neurology, speech, respiratory therapy, things of that nature, physical therapy, a variety of different things. I think the challenge is finding a group of people to fill those roles that you feel comfortable with, that have interest in the condition, and really have the same sense of service to this patient population that you do. And so that would be the ideal. I'd love to have one here in Buffalo. We've had peripheral talks about that are ongoing. But I think there's some questions in here related to this and how many cases you've done and how familiar with the condition you are. Those are all appropriate questions that should be asked. There's actually no question that you shouldn't ask while you're there. You need to be informed about the competency of the person who's treating you and informed about your comfort level in them treating you. So I don't think there's any question that's off limits.
Yeah. Go ahead.
The difficulty that we experience, and I don't know if it's because our healthcare system is structured this way, we put a referral in have a consult with a neurosurgeon, and if you see the neurosurgeon who's in Toronto at a major center, and you want a second opinion, you can't actually get an approved referral to see another surgeon.
Wow.
Because that surgeon will report back to your family physician who's brokering your health care.
Wow.
And say, well, the patient has seen Dr. X, and I can't offer anything like it, so I'm not going to say it. He says no.
So the question is, or the comment really is that it's difficult in some healthcare systems in Canada to get a second opinion because you've seen the neurosurgeon tick. The system's not going to fund you to see a second opinion.
You don't have a neurologist who first does a workup on you, again, in our situation, we're unfortunate. We did have a neurologist who cared for the patient population, but unfortunately, for reasons beyond understanding, is no longer available to see those patients and work them through that process.
So we've been able to work in, and maybe this is a model that others can include in their practice. We've been able to work in a nurse practitioner. So people that come from out of state in particular, they're going to see me for an hour. I will decide if they need additional tests. Day 2 are those tests, but they spend an hour with a nurse practitioner. They go into sleep, nutrition. But one of the key things is the social situation that I'm not going to be able to pull out of them. Occasionally, my nurse practitioner will say, you're not going to help this person. I know there's a Chiari, but you're not going to be able to help them unless they start getting that family situation together. We use what we call talk therapy because that's a more acceptable term to begin to unravel some of these situations. And some are just socioeconomic, if you will. They're really in a burden stress. So yes, obviously, eventually we want to redirect that patient, and eventually, hopefully, they'll come back into the system and be able to have their. But for me anyway, I can't overemphasize the importance of training up a series of nurse practitioners because they're the glue. One of your questions is asking, is it the neurologist? Is it the family practitioner? Is it the neurosurgeon that's going to follow me long term? For us, it's certainly been the nurse practitioner. has been a powerful piece of the puzzle for us.
In the UK, the Anne Conroy Trust keeps a list on their website of surgeons with an interest. It doesn't say they're any good, but it does say they have an interest. And so one of the issues that you seem to be describing is, you know, there's so many surgeons in the US, isn't there? I mean, you can't walk but for me bumping into people. And it just suggests that there's people who do at least come to the meetings, who do have some knowledge of it. Because for a patient, it can be really difficult to know how to find somebody that at least has an interest. I mean, the other thing, you know, the other thing you can do is look if they're published, look if they've published anything on it.
And it's difficult for surgeons to report on outcomes that are hard to measure. So, for example, headache, it's hard to measure, right? And so if you go to a surgeon and say, what's your headache outcome? They can say, oh, you know, it's pretty good. Most of the patients get better. But you can be more specific about answering questions about complications. What is your CSF leak rate? How often do you need to reoperate on patients? What's the length of hospital stay and so on? So these are questions that are fair and I think surrogates of outcome.
One final thing I want to say is that the internet is not always your friend. So for instance, a lot of the measures that are available for patients to assess whether or not their healthcare provider or their hospital system is performing good care and having good outcomes are heavily skewed. So for instance, locally, Kenmore Mercy, which is a small hospital, has the highest ratings of any of the local hospital systems, but that's also because they do very low-risk procedures on very healthy patients, so that data is skewed as opposed to a place like Buffalo General that's taking care of very high-risk, complex patients whose outcomes by nature of what the patient population walking through the door is going to be is already skewed. And the same thing goes with online ratings of physicians, websites that have been designed. I think there's, if anybody's listened to the Dr. Death podcast, that neurosurgeon down in Texas, they had this specially designed website with people he was paying as actors, highlighting that they were patients and had these great outcomes. So you just have to be aware that everything out there is not necessarily accuracy behind it.
And there is an AilerDanalyst.com website, I think you know, and I decided to check it again. At the top, there's professions, and you pull down the menu, and they have a directory. I've not studied that directory, but reach out is needed.
Okay. Well, very last question, I think. Yeah.
I was just curious if the underlying diagnosis, say it was EDS, is enough. And I don't know if this was decided this week or still being evaluated, or maybe different in different countries. But if underlying diagnosis was reason enough for not following surgical indicators for things like fusion, because as you noted, there's capacity to do the surgeries, but they're clearly not being universally made available, at least not our experience. So I'm just curious if an underlying diagnosis is criteria enough to not follow surgical indications.
No, I mean, I think that it comes back to that issue of what are the indications, and any comorbidities or associated conditions would always be taken into account. I think that just really comes to the point where we don't really have good evidence to say what are the specific indications. We will have to sort of close things there. I want to just really thank the panel. They've worked really hard this morning, and